Welcome to the EAU Podcasts. In this episode, UROONCO Kidney Cancer Chief Editor Dr. Carmen Mir talks to Associate Professor Tian Zhang on the trial's results on metastatic kidney cancer, which discussed at ASCO GU 2025.
Hello, everybody, and welcome to another podcast episode from the EAU UROONCO platform, Kidney Cancer. We are here today at ASCO GU25 in San Francisco on St. Valentine's Day, and we have with us Dr. Tian Zhang. She's a medical oncologist, associate professor at UT Southwest, and she is in charge of clinical research within the university. And she is going to talk to us about some trials have been discussed in metastatic kidney cancer at ASCO GU, very interesting changes. She's going to give us her feedback. And please, can you tell us, Tian, what is your take-home message of what you are discussing at the plenary session on Saturday?
First, thanks so much, Carmen, for having me on the podcast. It's really an honor to talk with everyone at EAU about GU ASCO kidney cancer trials that have read out. In the kidney cancer space, we have a pretty crowded frontline metastatic space, but what we've seen is multiple immunotherapy doublets have improved survival outcomes. And so we saw the final follow-up of Checkmate 9 ER, which was a frontline trial that randomized treatment-naive metastatic kidney cancer patients to either cabozantinib with nivolumab or sunitinib. And we had already seen some of the early data that showed improved progression-free survival as well as overall survival. And with the 67-month follow-up that we saw at GU ASCO this year, we're seeing sustained improvement in survival follow-up. So I think the message that immunotherapy doublets are certainly our standard of care now for frontline metastatic disease. Absolutely. Here to stay. Exactly. We then saw the first triplet trial to read out, and this actually was Cosmic 313. It had first read out at ESMO about 2 years ago at this point. But again, all clear cell kidney cancer, no prior systemic therapies, randomized to either receiving ipilimumab, nivolumab, or the triplet of ipilimumab, nivolumab, and cabozantinib. And the premise was that hopefully we would increasing and intensifying treatment up front. We would improve complete responses. We would get people to live longer, and we would also improve progression-free survival.
So that was the rationale.
That was the rationale, okay. Absolutely, and to really push out and get to durable responses. Mm-hmm. And so the follow-up data that was updated in the intention to treat population, there is some incremental difference between cabo ipi nivo triplet versus ipi nivo, but as we saw, the intermediate risk disease was incrementally better, but poor risk disease, there was some crossover of those curves. And so in particular, I think patients with poor risk disease are not set up so well to take treatment breaks. And so we did see less overall average daily dose of cabozantinib for patients taking the triplet combination. We saw also fewer doses, fewer cycles of ipilimumab. So there's a school of thought that people need all 4 cycles of their ipilimumab CTLA-4 blockade. And so there are fewer patients who received all 4 cycles. Most of these patients, 92% of them had any dose modification, and about half of them had some discontinuation of one of those treatments. And so I think all of those details of how patients receive treatment ultimately led to the patients with poor risk disease having that crossing of the curves and poor outcomes overall. However, there was an interesting, I think, tantalizing, provocative biomarker story, and that is of the M2 high tumors. There are about 50 tumors that were categorized as M2 high in each cohort.
What is M2 high?
Yeah, so M2, tissue-based macrophages are classified usually as M1 or M2. And so M1 are more tumor suppressing, more inflammatory. M2 are more tumor suppressing, and they're more macrophages that suppress the immune effect. Well, it's interesting. So the M2 high population in this particular trial, there were about 50 in each cohort that were received cabozantinib versus not. And if you look at the M2 high tumors, those patients were likely to benefit from cabozantinib for both progression-free survival and overall survival. But if you look at the M2 low patient populations, interestingly, the curves overlap, and those patients actually don't have a benefit of cabozantinib in addition to their to the immunotherapy doublet. So it begs the question, if we were to enrich this trial for M2 high tumors, would those patients be more set up to respond to the triplet? So unfortunately, we did not see a signal across the population of the triplet versus the doublet. But I think interesting biomarker changes of the tissue microenvironment, these M2 high tumors, certainly needs external validation in another trial to see that effect.
A work in progress.
That's right. We saw the results of Keymaker U03. This is a bucket trial of sorts with refractory metastatic kidney cancer. Patients were assigned and randomized to either lenvatinib, pembrolizumab, which is sort of the control cohort of sorts, lenvatinib with belzutifan, or pembrolizumab with belzutifan. And so this is really trying to see the component of each of these treatments in the refractory kidney cancer setting. And interestingly, the patients who had lenvatinib with belzutifan had high objective responses, almost 47% of a sample size of 64, and high median progression-free survival about over 12 months. And so, limited sample size, I would say, but it is the highest objective responses we've seen in refractory trials. So I think it's an interesting combination, has a disease activity in the refractory setting, and there's an ongoing registrational trial called LIGHTSPARK-011 that is randomizing patients with refractory disease to either belzutifan with lenvatinib or to cabozantinib. And so we are still awaiting the results of that trial.
So based on what you told us, does it change your clinical practice for first line? Would you still go for the classic ipi-nivo for first line, or does it change anything for you?
Yeah, so to me, my discussion really centers around this heterogeneity of clear cell kidney cancer. I think there's a lot of different subtypes and a lot of molecular drivers, and those of us who see kidney cancer knows it comes in many different flavors. And so I think we, as a field, should start thinking more molecularly, think beyond those prognostic classifications, and try to think about what is driving disease biology. And I would say that right now, we don't have all the answers. If that's an M2 high signature, an angiogenesis signature, is it KIM1, a biomarker in the adjuvant space? We recently published some interesting cytokines like macrophage inflammatory protein. So there's some interesting signals out there. I think most of these biomarkers still need to be validated and be tested prospectively. But if we are able to enrich those trials with the patients who are likely to respond, then we hopefully we'll find better paths and more suitable treatments, more personalized approaches, if you will, for those patients. And that's what I hope we will ultimately get to, is prospectively being able to help our patients make the right treatment decisions.
So something like is happening in bladder for FGFR, for example, it might happen at some point for the kidney cancer.
I hope so. That's right. Exactly. So a targeted approach for an oncogenic driver. And if we can find those in kidney cancer, I think will be a more rational approach to making sure we find the right patient for the right treatment.
Thank you so much, Tian, for taking time to be with us today. And we hope to see you soon.
Thanks so much, Carmen. Really great.
Thank you for listening to this episode of EAU Podcast. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU Podcast channel for regular updates.